Hello and happy Teach Me Tuesday. My name is Lisa Houston and I'm a clinical nurse educator specializing in the NICU. Today we are going to talk about a requested topic, and that is IVH versus PVL versus hydrocephalus and kind of how they all play together. If you've been following along for a little while, we have done an IVH topic in the past. So if you wanted to dig in a little bit more to some of the prevention and treatments, you can go back. I believe it was in October of last year. I don't know, maybe it's been a year. I don't think it's been a year, but it's been a minute. But you can go back and find that original recording. We are going to talk about IVH here, but we're not going to go into so much of the details of the prevention and the treatment. Talk about it briefly. But let's just do a quick review. So IVH, intraventricular hemorrhage, PVL, periventricular leukomalacia, and hydrocephalus are all neurological conditions that do, in a way, kind of play into each other, right? You can have each of them individually. You can have IVH without PVL. You can have PVL without IVH, and you can have hydrocephalus without IVH. But you will also see them coming together. So we're going to kind of talk about how those are, similar, how they work together, etc. IVH is the bleeding in the brain's ventricular system. PVL is when there's white matter damage, usually from lack of oxygen, which can come in the same kind of setting that you get a IVH situation. And then hydrocephalus, which is often associated with severe IVH, is that abnormal accumulation of cerebrospinal fluid within the brain. We want to talk about early diagnosis, timely interventions, long-term neurodevelopmental outcomes, and how we can best support these babies. So let's start with IVH. IVH is the one we probably all are the most familiar with. Whether you work in a level 2, 3, or 4 NICU, you're probably seeing IVH. Hopefully, if you're seeing it, it's decreasing. Hopefully, if you're seeing it, it is the, grade 1 or 2. Severe IVH, which is our grade 3s and 4s, especially those grade 4s, is always the worst one. It makes our hearts kind of skip a beat every time we hear it when we're standing there in that cranial ultrasound. But in general, there is bleeding that enters this ventricular system, and it comes from highly vascularized areas, often occurring in the germinal matrix, right? Bleeding can be limited to there or can spread beyond, even into the brain parenchyma. We know it's diagnosed by cranial ultrasound on days 3 to 7 of life. Can you diagnose it sooner? The answer is yes, but it's not always diagnosed sooner, and you could have a normal cranial ultrasound at 24 hours of life and an abnormal one later at that 3 to 7 day mark. Most frequently, if you are participating in any sort of IVH prevention bundle, whether that's a 72 or 96-hour midlining and, golden hour, golden 72 hours, whatever your title is for this, in these IVH prevention bundles, you probably are delaying your cranial ultrasound until after that is complete, maybe even for 7 to 14 days. Maybe it depends on the gestation of your baby. I've also been a part of a situation where maybe we had a very extremely low birth weight baby, an elbow, ELBW, who really had a rough start at birth, right? They were 23 weeks, got chest compression at birth, and we actually did a cranial ultrasound very early to help parents make an informed decision on what they wanted to do next with their baby. That can happen. So it's not that we always wait till 3 to 7 days. So I just wanted you to kind of hear a little bit of the variances that can happen there. Outcomes are going to vary by the grade. Grade 1 IVH, sometimes it reabsorbs and we don't even really know that much about it. If you have IVH on one side versus both sides, your outcomes also can vary. Did you know that one side of the brain will make up for the other side of the brain? Pretty wild, especially when you're young and have a lot. So let's talk about the 4 grades. Grade 1 is that bleeding is limited to the germinal matrix. If you're looking at this, if you were looking, let's say, at an ultrasound picture, right? You've got it pulled up in your EHR, you're looking through it, and you're like, okay, I can see what's going on here. You're going to see this black area with like a little white poking out. That's what's showing you what the bleed is. So if you just see this little area, that's probably your grade 1. Your grade 2 is the blood is in the ventricles, but there's no enlargement. Grade 3, we are now seeing, the intraventricular extension is involving 50% more of the volume of the ventricle, and we've had some dilation. So in this grade 3 picture, you can see on the left side how that ventricle is starting to dilate. And grade 4 is 4 4 is that bleeding extends into the brain itself. This picture is from Radiopedia, which I think is a great source if you're looking for x-rays, explanations of ultrasounds. I've tagged it there, but I think it's a great resource if you're looking for that. So what are we going to do for these babies? We are going to do follow-up ultrasounds. We're going to manage their symptoms. Often we're going to be watching their hematocrit. Sometimes if we have a baby with a grade 2 and we see a dramatic drop in their hematocrit, we may do another ultrasound sooner. We may, if hydrocephalus occurs, need to consider either a VP shunt or some supportive measures, a reservoir for this baby. So something to think about what they may need there. So what I want you to take away from this slide is in this grade 1, you can see in that limited area there, it really does have the opportunity to be reabsorbed. And that's a great situation. It may not happen, but less likely for the baby to have severe long-term effects if it is a grade 1. In this grade 4, you can see that ventricle, not only is that ventricle full of blood, but it has pushed out into the brain, and that brain tissue is not going to develop normally in the setting of this IVH. And that's where we have some of our long-term outcomes due to severe IVH, which is considered your grade 4s. So PVL is periventricular leukomalacia. So this is damage or death of the white matter near the ventricles due to lack of blood or oxygen. This can happen because of IVH. IVH can cause some of this death, this damage around the area of the bleed. PVL can also be caused by lack of oxygen before, during, or after delivery. So a baby can develop PVL because they coded at their delivery, because they had a intrauterine situation such as an abruption or something going on with them that could cause it. PVL can also happen in a setting of a NICU code or just times a really sick time that baby has had where they're on 100% oxygen and we can't keep their oxygen levels up. So these are all things to consider. PVL is not always limited to our extremely low birth weight infants either. I have heard of bigger babies closer to term who also have PVL because of this setting of oxygen deprivation. So we will see some symptoms here. PVL is definitely harder to see as a NICU nurse. You're not going to necessarily see it right away. You might see some muscle stiffness, tightness, spasticity. No, I'm not going to say it correctly today, and we're all just going to agree that I can't say it correctly today. Long term, you're going to see more things such as cerebral palsy, vision problems, hearing problems. I've actually heard of some older, like late preterm infants or, those 37, 38 weekers who start having some of these developmental delays, maybe with their motor. They go in, they're getting some checkups, they end up with an MRI, and it shows their PVL there. Do we always know that a NICU baby has PVL when they leave? No, but we know most of them. So PVL in the setting of severe IVH, when those two things go together, or you have cystic PVL, where the areas of the brain have actually formed cysts from the death around it, those are the most severe, and those are the babies that are going to have the worst outcomes, that they're just going to have more to overcome, right? They're going to have more comorbidities. They're going to need more supports to help them throughout their life. So just things to think about as you are kind of putting these things together. So again, it can lead to cerebral palsy, cognitive delays, motor impairments. There's no cure. So what you're seeing in these x-rays here is kind of pointing at this like white areas, these patchy white areas within these images. You see along the side here, at the bottom. All these areas are just parts where you're looking at a cranial ultrasound and there has been death of the tissue. So we want to make sure we keep these babies in a good target saturation. They are going to need early intervention with their physical and occupational therapy to manage those motor impairments, ongoing neurodevelopmental follow-ups so that we can make sure we're getting them early intervention, getting them involved in their school districts early and often, and providing those resources for those early intervention programs. Here in the area I work in, we have parents as teachers. We have people that will come into your home and help you manage some of these symptoms, doing physical therapy and occupational therapy at home. I've said it before and I wanted to say it one more time. The occupation of a baby is to be a baby. So occupational therapy in a baby is to help them be the best baby they can be. Maybe that's learning how to crawl. Maybe that's learning how to feed better. Occupational therapy is so important, even for babies, which always seemed a little weird to me. So let's talk about hydrocephalus. Hydrocephalus occurs when the CSF accumulates in the ventricles, and this causes pressure on the brain. It can happen from severe IVH, where the ventricles are full of blood, which then causes all this reabsorption issues to kind of get out of whack in the brain. And so we have this fluid where it can't go anywhere, right? So your cerebrospinal fluid is your CSF that goes up your spinal cord into your brain, and it's got all this movement going around. And if it can't move because of a blockage from the bleeding, we have situations. We also have hydrocephalus for other reasons, right? So there are some birth defects associated with hydrocephalus. We can get hydrocephalus from some trauma. So it's not just from severe IVH, but that's how these two are linked together. Here you can see that in this setting of your normal ventricles, when they're full of fluid, they're going to push out and put this pressure. That's why we're always checking for their fontanelles. Are they bulging? Obviously, once they have a shunt in, we don't want them to be sunken. These babies may be irritable. It's almost, I just picture it kind of like almost this kind of chronic headache going on. If you're noticing rapid changes in your head circumference, hopefully on your unit, you're checking your head circumference at least every week. In babies with severe IVH, you're probably checking it daily or the minimum 2 times a week to watch for this rapid change. So if untreated, the hydrocephalus can lead to significant brain damage and developmental delays. A baby may end up with a reservoir, which is kind of like it sounds. It goes into the brain and it can be tapped, and we can pull the excessive fluid off of it. And then kind of the long-term solution of that is the VP shunt. So the purpose of a VP shunt is to remove excessive CSF from the brain and move it to the abdomen where it's absorbed into the body. This is performed in the operating room. They place a catheter in the brain ventricle. They place another catheter under the skin with a valve. Most babies, after surgery do well. There can be complications with this shunt. It can have shunt failure. You can have kind of clogging. It can back up. It has improper draining. Obviously, infection is a huge risk, whether it's at the site of the shunt or the site down in the body. You're watching for signs of infection, temperature, irregular temperature. And of course, if your OFC is increasing in size again, there's signs that maybe your shunt isn't working. So a baby can have severe IVH without hydrocephalus, but you can also have hydrocephalus without IVH, but you can also have severe IVH and hydrocephalus together. So that's kind of how they all go together. So just a little recapping of these 3 things. IVH is the bleeding into the brain, into the ventricles specifically. PVL is damage to the white matter, and hydrocephalus is the buildup of the CSF. So here you can pause me, take a screenshot, look at this. This is kind of just a gentle reminder of all the things you've gone over. Hydrocephalus, we really are watching with cranial ultrasounds, eventually needing an MRI for both PVL and hydrocephalus. Not something that we're obviously taking a micropremature infant down for an MRI. This is going to be when they get bigger and are more stable and can get down to the MRI machine. IVH, we're going to see some symptoms. We might see a dramatic change in their hematocrit. That would be something else. Obviously, if we see seizures, apnea, bradycardia, that would alarm us that something might be going on. There's not a lot we can do for IVH and PVL. So it's really important to kind of keep that in mind, which we're going to talk about kind of, this idea of how can we help these babies the most. So first of all, we're going to help their parents. When you have a premature baby, or a baby that's in the NICU, you're already got your laundry list of things to worry about. So this is another thing that they have to worry about. It's another thing that they don't know they have to know to worry about it until it happens. So it's an unexpected outcome. It's maybe something that they've heard about if their baby is extremely low birth weight or extremely premature, born less than 26 weeks. We're more likely to kind of give them warning, but this can happen in a 28-weeker. I've seen a 28-weeker with grade 2 and 3 IVH, so it's not limited to just our smallest patients. We tend to have kind of our conversations about things the smaller the baby, so just remember that your parents may never have heard of this. Encourage them to ask questions, to participate in decision making. This is again why we do some cranial ultrasounds on our very low birth weight and extreme premature babies, those 22 and 23 weekers early. So if we need to have some decision conversation with parents. And then making sure they're getting emotional support, connecting them to counseling service, and then having their follow-up care. This is another screen that I think that you could just pause me and take a screenshot of. One sentence, one phrase that you could say for each one that's got simple words for your parents to understand. IVH is when bleeding happens in the brain's ventricles, which can be common in premature babies and may affect their brain development. PVL is a brain injury where certain areas didn't get enough oxygen, leading to damage in some of the white matter, which can affect movement and development. Hydrocephalus happens when too much fluid builds up on the brain, causing pressure, and we may need to get a drain in there to help prevent further complications. So things that are kind of easy to just start with, and then allow them to ask questions. What questions do you have about IVH? What is concerning you? What's keeping you up at night? What can I help clarify? Would you like me to have the doctor come in and we can look at these ultrasound results together? Would you like to see comparison from one ultrasound to the next? Those kinds of things kind of together are going to help you be successful in how you're helping your parents through this. So here's the thing I want to talk about the most, which is on here, which is prevention. Anything that we can do to prevent this is going to increase the baby's long-term outcomes and reduce their comorbidities. So if your unit does not have an IVH bundle or a golden hour bundle or midline positioning, something like that, that's a way that you could get involved to help drive change on your unit. You know, we talked earlier in 2024, if you didn't see it, about new beginnings and how nurses can affect the outcomes of their babies by implementing evidence-based practice. Maybe you're delivering smaller and smaller babies. You may need to have a two-pronged approach to your golden hour or your IVH bundle. Maybe you have an IVH bundle that is working great for your 25 weekers, but you're still having 23 weekers and 22 weekers with brain bleeds. It's really important to remember that a 22 weeker is not just a small 25 weeker. Everything is smaller and more fragile. Their skin is different. Everything is going to be different for them. So maybe you need to just have two bundles. So prevention is key. Doing care bundles, midline positioning, gentle ventilation, not using conventional ventilation unless we absolutely have to. Maybe doing something like jet ventilation where we have smaller puffs of air into the baby so that they're not getting overexpanded, which is affecting their heart flow, which is affecting the blood flow to their brain. Lots of evidence-based practice, keeping the bed elevated, not lifting the legs for diaper changes. All of those things can help prevent the severe forms of IVH, which is going to reduce your risk of PVL and reduce your risk of hydrocephalus. We also need to tell our parents, hey, did you notice how we're changing the diapers? This probably looks really weird compared to your term baby that you had where you were trying to just change them while they're kicking and everything. The reason we're not lifting their legs. Or have you noticed how we give medications really slowly? And when we draw our blood, we're doing it really slowly. And if we have to flush a line, we're doing it really slowly. We're trying to prevent major fluctuations in the blood flow to your baby's brain. Here's why. Here's what we're trying to prevent. Those are things that you as the bedside staff can do to empower yourself and your families to change the outcomes of the babies in your NICU. And I know you can do it. If you have any questions, please DM me. Follow me on Instagram. Follow me here on YouTube. But you can find me and we can talk about this and I can help you with some strategies. But hopefully this was helpful in breaking down the differences between IVH, PVL, and hydrocephalus. And I will see you next week for another round of Teach Me Tuesday. Have a great day.